A 33-year-old man attended a party. This led to his admission to the intensive care unit. It was supposed to be just another weekend get-together, the kind where laughter fills the air and worries seem a world away. But that night something went terribly wrong, and it turned into a vigil by a hospital bed praying for a friend's recovery from something none of them had heard of before. A toxic alcohol ingestion. The gathering. Friends gathered at John's place, a usual spot for our weekend escapades. Drinks flowed freely as they often did, and the evening stretched into the night. John was in high spirits, laughing louder and drinking more than usual, but they thought little of it. After all, wasn't this how they always celebrated? As the night wore on, they noticed John's laughter turning into slurred speech, his steps unsteady. They joked about it initially, teasing him about his tolerance. However, as the hours passed, his condition didn't improve with rest and water as they expected. Instead, he grew increasingly confused, his words jumbled and his movements sluggish. It was unlike any hangover symptom they'd witnessed. By morning, their concern had turned into alarm. John was barely responsive, unable to hold a conversation or even sit up straight. His symptoms were far beyond anything they'd seen from too much alcohol. Acting on instinct more than knowledge, friends decided to take him to the emergency room. It was a desperate decision, fueled by the fear etched on John's face. The hospital's emergency room was a flurry of activity. As they explained John's condition and his recent binge, the medical team sprang into action with a sense of urgency that heightened our fears. They mentioned toxic alcohol ingestion as a possible cause, a term that sent chills down our spines. They watched helplessly as they wheeled John away, his condition a stark reminder of our night's potential consequences. John, a 33 man referred to as the patient, was brought in with altered mental status, presenting a puzzle that demanded both swift action and deep medical insight. Upon the patient's arrival, Dr. Emily conducted a thorough examination, noting the distinct smell of alcohol on his breath and his disoriented state. Initial lab results showed a significantly low pH of 7.19, indicative of severe acidosis, and a high anion gap, which often signals the presence of unmeasured anions in the blood. These findings raised an immediate red flag for possible toxic alcohol ingestion, a condition that, if left untreated, could have dire consequences. Faced with the urgency of the situation, Dr. Emily initiated a treatment protocol aimed at addressing toxic alcohol poisoning. This approach included administering intravenous fluids and fomepizole, an antidote that inhibits alcohol dehydrogenase, preventing the conversion of toxic alcohols to more harmful metabolites. Additionally, bicarbonate was given to correct the acidosis. However, despite these interventions, the patient's improvement was minimal, prompting Dr. Emily to reconsider her initial diagnosis. As Dr. Emily delved deeper into the patient's medical history and symptoms, she contemplated the similarities and differences between toxic alcohol poisoning and alcoholic ketoacidosis, aka. Both conditions can present with high anion gap metabolic acidosis, but they diverge significantly in their etiology, clinical manifestations, and management. Toxic alcohol poisoning resulting from the ingestion of substances like methanol or ethylene glycol typically presents with gastrointestinal distress, altered mental status, visual disturbances, and potential renal failure. The diagnosis is supported by laboratory findings of high anion gap metabolic acidosis alongside an elevated osmolol gap. In contrast, AKA arises predominantly among individuals with a history of heavy alcohol use who experience a sudden reduction in intake, often exacerbated by poor nutritional status. It manifests as severe acidemia, tachypnea, tachycardia, and abdominal pain. Unlike toxic alcohol poisoning, AKA does not involve an elevated osmolol gap. The presence of ketonuria or elevated serum ketones alongside a high anion gap metabolic acidosis can help confirm the diagnosis. Reevaluating the patient's condition through the lens of these insights, Dr. Emily ordered a serum ketone test, which revealed significant ketoacidemia. This pivotal finding shifted the diagnosis towards AKA. The patient's clinical picture, characterized by his chronic alcohol use, the recent decrease in alcohol consumption, and the absence of an elevated osmolar gap, aligned more closely with AKA than with toxic alcohol ingestion. Dr. Emily promptly adjusted the patient's treatment plan with this refined diagnosis. The focus shifted to aggressive hydration, administration of dextrose to suppress ketogenesis, and thiamine supplementation to prevent potential complications such as Wernicke's encephalopathy. This targeted approach led to a gradual but marked improvement in the patient's condition. His acid-base balance normalized, and his mental status improved significantly over the following days. AKA is primarily caused by excessive alcohol consumption, leading to a significant reduction in NADH, particularly in the context of poor food intake. Toxic alcohol poisoning results from the ingestion of substances like methanol or ethylene glycol. AKA patients can present with severe acidemia, tachypnea, tachycardia, and abdominal pain and acidemia. However, some show a pH greater than 7.35. Toxic alcohol poisoning manifests as gastrointestinal distress, altered mental status, visual disturbances, and renal failure. AKA is characterized by elevated anion gap acidosis, ketonuria, occasionally ketoacidemia, and electrolyte imbalances such as hyponatremia and hyperkalemia. Diagnosis is often clinical, supported by laboratory findings. Toxic alcohol poisoning shows high anion gap metabolic acidosis, an elevated osmolol gap, and the presence of specific metabolites, formic acid for methanol, glycolic and oxalic acids for ethylene glycol. AKA treatment focuses on aggressive supportive care, including hydration, dextrose, and thiamine administration. Toxic alcohol poisoning requires specific antidotes, fomepizole or ethanol, and in some cases, hemodialysis. Both conditions present with a high anion gap metabolic acidosis, indicating the presence of unmeasured anions in the blood. A significant distinguishing factor, particularly in AKA, is the presence of elevated ethanol concentrations in the blood. However, both conditions can involve alcohol use, with toxic alcohol poisoning often due to intentional or accidental ingestion of toxic substances. The overlap in elevated anion and osmol gaps can make it challenging to differentiate between these two conditions based solely on these metrics. Rapid testing for toxic alcohols and recognizing the presence of ketone bodies are crucial for accurate diagnosis. Both conditions present with a high anion gap metabolic acidosis, indicating the presence of unmeasured anions in the blood. A significant distinguishing factor, particularly in AKA, is the presence of elevated ethanol concentrations in the blood. However, both conditions can involve alcohol use, with toxic alcohol poisoning often due to intentional or accidental ingestion of toxic substances. The overlap in elevated anion and osmol gaps can make it challenging to differentiate between these conditions based solely on these metrics. Rapid testing for toxic alcohols and recognizing the presence of ketone bodies are crucial for accurate diagnosis. This case underscored the critical importance of a comprehensive assessment and the willingness to reevaluate an initial diagnosis in the face of evolving clinical evidence. Dr. Emily's experience highlighted the challenges in differentiating between toxic alcohol poisoning and AKA based solely on initial presentations. It emphasized the value of a detailed medical history, careful consideration of clinical findings, and the judicious use of laboratory tests in guiding diagnosis and treatment. Through diligent analysis and adaptive treatment strategies, Dr. Emily navigated the complexities of this case, ultimately ensuring a positive outcome for her patient. Thanks for watching Medical Toxicology. Take care and be well.